Good morning, everyone, and welcome to day 2 of the Small Communities Big Solutions Conference. I'm your host today, Dreama Mace with West Virginia School of Osteopathic Medicine. Just like yesterday, we have an extremely impressive lineup, so let's review some logistics and some important announcements, and then we'll get started. So first, I'd be remiss if I didn't salute the planning committee. They put in long hours to connect us with powerful programming this week. They're doing a great public service, and we all say thank you. Also, we could not do what we do if not for our loyal sponsors. Our program sponsor, United Bank, Appalachian Power, AARP, which you'll hear from later this morning, Marshall Health, which is sponsoring one of our impressive breakout sessions today. And both AARP and Marshall Health are critical sponsors of today, and we appreciate their support. In addition, other sponsors include West Virginia American Water, Marshall University Research Corporation, West Virginia Municipal League, and West Virginia Executive Magazine. Thank you all. And now here's a reminder of our conference rules. We all have to learn something new. We have to take something back to our community. We have to check the schedule on www.westvirginiasolutions.net. This is your online program book. So that's www.wbsolutions.net. Dr. Marsh and Dr. Kelly will be taking some questions. So put your questions in the Q&A section with your name and email. In case we don't get to all the questions, if you have your email in there, then we can send you the answers. But make sure, I know Dr. Marsh wants to do his presentation very interactive. So get those questions in there early so we can have an interactive conversation while we have him here. Please remember that we're here to discuss West Virginia and here to celebrate. So please be constructive and stay positive this week. Take a photo and tag hashtag West Virginia Solutions on social media for your chance to win a $25 gift card throughout the conference. Let's highlight our state and get people talking about West Virginia. Reminder that today's morning session will be recorded for future reference. For those of you who are wanting continuing education credits for today's sessions, please remember to put your name and email in the chat for each morning session and each breakout session, because that's how we're taking the roll so you can get your CEUs. And be sure to try your luck during our game show giveaway daily at 11:15 a.m. on the morning session conference link. We're giving away multiple 50
institution of that organization, Coalfield Development, and the West Virginia Community Development Hub. I especially want to acknowledge the work of Sarah Payne Scarborough, Operations Council Chair for the Alliance, Stephanie Tyree, Executive Director of the West Virginia Community Development Hub, and Brandon Dennison, Founder and CEO of Coalfield Development, as well as the members of the program committee who have just put together a great conference. Well, I heard we had a good day yesterday on our economy, and as I said, today we'll focus on our health. Certainly, we've seen the impact of disease on our state, especially during these times, the effects of COVID-19 on our state and the effects of the opioid epidemic. It's so clear that coming up with solutions, working together, having conversations like these is critical for the future of our state. We have serious problems, but I think together, what I know we can do as West Virginians is we can meet these challenges as we have been. Today's lineup of speakers will focus on updates on COVID-19, as well as other major health crises like the opioid epidemic, exploring areas of prevention and recovery, talking about stigma, which is a really important subject to focus on. Of course, we face multiple health challenges in our state, and some of it is due to our aging population. So we have a session on the importance of health policy issues that affect people over 50. You know, I know there's concerns about healthcare accessibility and affordability as people age. And then we'll end our morning on strengthening our behavioral health workforce, which is needed more than ever. Without a doubt, you know, mental illness and just the struggles people are having during these times, we really need to continue to build our behavioral health workforce. I thank everyone for presenting today. Before I introduce our first speaker, I'd like to share some of the work the West Virginia School of Osteopathic Medicine's Center for Rural and Community Health is doing as it relates to the school's response to COVID and the pandemic and the opioid epidemic and other healthcare challenges. The center is overseen by my Vice President for Community Engagement and Development, Dr. Dreama Mace. And the work I'm going to mention was done by the center's staff members. But before I briefly touch on the projects, I want to make you aware of our Center for Community Engagement, which is the Klingman Center. Hopefully when it gets safer and people are traveling, hopefully you'll come visit us here in Lewisburg. You're always welcome. And if you go to the downtown of Lewisburg, there is one of the coolest places and one of the coolest towns in the country, coolest small towns in the country. There's an area called Montwell Commons. And you know you're in Montwell Commons because there's a great gourmet pizza place there called Hill and Holler, and a wonderful place to get ice cream and cupcakes, Amy's Cakes and Cones. But down in Montwell Commons is a structure, a barn-like structure called the Klingman Center for Community Engagement. And this is leased by WVSOM. Actually, the barn structure is interesting because if you know Mark Bowes from Barnyard Builders, this was one of his first projects. It's a beautiful building. So this is where the center runs many of its local community engagement outreach programs. So what am I talking about? Well, you know, I'm talking about things like we have a little garden, so we teach people how to grow food. We have an industrialized kitchen, so we teach people how to cook food. We teach people how to change their lifestyles to address their chronic illnesses, their chronic diseases. It has become a hub for our COVID-19 response activities in the community. And we've done such projects over the months, such as K95 mask production, preparing food in safety bags for essential workers. I mean, one of the best projects was we prepared these bags and we distributed them at rest areas on the interstate to the truckers who just loved it. You know, we've helped organize and fund PPE orders and distributing them to frontline service organizations. This was essential, especially at the beginning of the pandemic. We have a project called the Be Kind Project that teaches children who have returned to school how to wear masks, how to socially distance and sanitize and, you know, use proper hygiene. And that's especially important for young children. My favorite was the Saving Businesses Feeding Seniors program. So what that program was all about was we had grant funds and then raised funds actually to allow 8 local restaurants to prepare foods for seniors who were shut in during the lockdown. In fact, many of our students and center staff, safely delivered these meals to seniors. What a great project! What a win for the wonderful restaurants in Lewisburg. What a win for the seniors who couldn't get out and needed the food, and then what a win for our volunteers who really wanted to do something and become engaged in the response. The Center for Rural and Community Health also has been at the center of WVSOM's response to the opioid epidemic. This epidemic continues, and it's just ravaging individuals and families throughout our state. Projects have included the creation and distribution of 6 regional and 11 county opioid toolkits. If you haven't seen these, or if you need them, please let us know, let Dr. Mace or myself know. They're an excellent resource. We've done 2 series, 2 years in a row. We did a series, an opioid series for our osteopathic medical students. It's really important to teach medical students the impact of the opioid epidemic. And we have evidence to indicate that this series, in fact, helped change attitudes, helped address the stigma that you see in people regarding people who are addicted, especially to opioids. And then we have a very robust anti-stigma public service announcement campaign to, again, continue to get the message out. And finally, we've been involved in the Learning Collaborative, which consists of 12 higher ed institutions across the state who have created a recruitment and retention plan for behavioral health professionals, which will become part of the Governor's Advisory Council's statewide opioid prevention and treatment plan. So great work from the center, from our center, and it will continue. Clearly, WVSOM and the center is living its mission to serve West Virginia first and foremost, addressing the healthcare needs of its citizens. So now I have the honor of introducing someone who really does not need an introduction, since he is one of West Virginia's foremost healthcare leaders, Dr. Clay Marsh, MD. Dr. Marsh is, of course, West Virginia's coronavirus czar, but he's so much more than that. He is a national leader in personalized medicine and in pulmonary and critical care. He currently serves as the Vice President and Executive Dean for the West Virginia University Health Sciences Center. Clay grew up in West Virginia. He earned his bachelor's degree in biology and his medical degree from West Virginia University. He then went on to complete an internal medicine residency and research fellowship in pulmonary and critical care medicine at The Ohio State University. I guess he liked it there because he stayed around for 30 years in Ohio and spent them at The Ohio State University, where he served as Senior Associate Vice President for Research in the Office of Health Sciences, Vice Dean for Research in the College of Medicine, and Executive Director of the Ohio State University Center for Personalized Healthcare. Fortunately, he returned to the Mountain State in 2014, and we are so grateful for that, to have somebody so talented and so accomplished. And he serves his alma mater, leading WVU's Academic Health Sciences Center, and he oversees the schools of dentistry, medicine, nursing, pharmacy, and public health, as well as their robust research enterprise, numerous allied health programs, and the clinical operations for WVU medicine. I don't know when he sleeps. It's just an incredible contribution. You know what I love about Clay Marsh is his humility, his passion for taking care of others, and his love of his home state, West Virginia. Without a doubt, you know, it was not a surprise when Governor Jim Justice selected him to lead his coronavirus team at the start of the pandemic as the state's coronavirus czar. So Dr. Marsh is with us today to provide an update on the pandemic and the impact on West Virginia. Thank you, Dr. Marsh, for everything you do for West Virginia.
Well, thank you so much for that overly kind and generous introduction. And President Nemitz, congratulations to you and to the West Virginia School of Osteopathic Medicine for the incredible difference that you and your team make every day in the life of West Virginians. That's greatly appreciated, and the partnership is also greatly appreciated. And for Dreama and Sarah and the team, thank you guys for putting this wonderful conference together. Wow. So what I'd like to do in the next 30 to 40 minutes or so is to give you the Monarch Notes version, the Cliff version of what's going on with COVID-19, how it may interface with some of the other problems that we see in the public health domain and population health domain related to isolation, hopelessness, drug addiction, et cetera, but also do this in a way as Dreama introduced. And by the way, for everybody here, I'm Clay, so please. And so what we'd like to do is have questions from the audience submitted so that we can address things that are really more relevant to what you are interested in. So let me start off with 3 quotes that I love by 3 different people. So the first quote is by a philosopher named Anna S. Nin, and she said, "We don't see things as they are, we see them as we are." And I think that that's really, to me, clear from the recent, election to the issues of implicit and social race and bias and some of the polarization that we've seen across media and other portals, which is truth is really what we believe it is. It's the narrative that we give to the facts that we come into contact with. And one of the real opportunities to me during this pandemic, which we have seen, is all West Virginians starting to pull the rope, as the governor says, in the same direction. And that's probably the central, most important single issue for us in our successful approach to COVID-19. The second quote is from my favorite philosopher, is the Sufi philosopher Rumi. And Rumi said, "Yesterday I was clever and wanted to change the world. Today I am wise and decided to change myself." And to me, the second sort of lesson learned is that the ability for us to use our real power, which we have against COVID-19 and against all the other health issues that we are facing in West Virginia, really involves us changing our own belief system, our own approach to these problems. I am very deeply a believer that until we flip the scarcity or fear-based mindset of can't or don't deserve, or I am somehow overwhelmed by a external force that's too great, and turn that into I can, a mindset of abundance, of gratitude, and belief that all things are possible, then it's hard to get out of the health issues that we are experiencing in our state. And ironically, I am hopeful that COVID-19 will be at least part of that launching pad for us to really start to address some of the other important public and population health problems in West Virginia. The third quote, which I love, is by Lao Tzu. Lao Tzu is the person that translated the Tao, but it's spelled T-A-O, the Tao, which is the Bible of Hinduism and used in other religions, and Taoism, of course. And it is the journey of 1,000 miles starts with a single step. And I think that we've started to make these steps together. And so let me start as a primer on COVID-19. And COVID-19 is the pandemic of our lifetime. We haven't seen such a pandemic since 1918. And 1918 was the Spanish flu. And I want to come back and ask anybody on the call to tell me why the 1918 pandemic was called Spanish flu. That would be an extra credit bonus question, because the 1918 pandemic is actually H1N1 influenza that started in a pig on a farm in Kansas. So tell me how it was called the Spanish flu, and I'll be really, really impressed. It's an interesting, quaint story. Anyway, getting back again, these transmission of viruses from animals to people tend to be ones that are problematic because the animal host, in the case of COVID-19, the host was a bat, and it may have gone through an intermediate host called a pangolin, but probably came from a bat. And those viruses are more unique to our immune system. And so viruses that spread easily, which COVID-19 does, in people who are not immune to that particular virus can multiply and transmit very quickly. So let's go over why COVID-19 has created such a problem in the US and in the world. And just as a reminder, I think it was yesterday or the day before, the US just passed 11 million cases of COVID-19, and we've had close to 250,000 people who have died with COVID-19. And the reason why COVID-19 is so problematic is really three reasons. So number one, COVID-19 mainly transmits through aerosols or droplets that are generated by people who are infected with COVID-19 around people who are not infected with COVID-19. And the small aerosols, which are really small droplets, they are the ones that are the most infectious because they can get down to the lungs and into the airway the easiest. The larger droplets can still infect, but are a little bit less infectious. And the aerosols stay really close to the person who's expressing them, and the droplets span away from that person. And so we know that in situations where we see a lot of spread, which includes singing places, yelling places, speaking loud places, and even heavy breathing places, we start to learn that we produce droplets and aerosols from even quiet breathing, from quiet talking. They amplify when we talk louder, when we yell, when we sing, when we breathe hard. And that's the reason why in an environment where nobody is wearing masks, particularly indoors, with ventilation that's not turning over the air very rapidly or without the windows open, then those droplets and aerosols can build in those rooms and make those rooms much more likely to be places where you transmit infections. And that is really the key observation why we say masks are so important. Let me say that one more time. That is the key observation that tells us that masks are really important, because if you're wearing a mask that's a 3-ply mask, then you are not generating the aerosols or the droplets in the concentrations that you would without a mask. And those droplets don't stay dispersed as long, and they don't spread out as far from your body. So wearing a mask is really critical as a way to serve others, because you are not generating the aerosols and the droplets wearing a mask that you would if you didn't, and therefore you're protecting people around you if you would happen to have COVID-19. Now, the CDC's just reported that wearing a mask, and this is a 3-ply mask, it's a cloth mask, a silk mask, a mask you buy off of the internet with the ear loops that looks like a kind of a blue surgical mask. They all work fine. 3 plies is better. But the CDC has recently said the mask also tends to protect you by wearing it from droplets and aerosols that others generate. So a mask serves others by keeping you from infecting them, but it also protects you. And we know that if 80% of people in our country or in West Virginia would all wear masks and be around each other, then we would have an impact on the spread of the virus like we will with a vaccine. And if 90% of people wear a mask around each other effectively, over your nose, over your mouth, then we will have the impact on the virus better than a vaccine. So we have the power, and the power is everybody wear a mask. And if you wear a mask and you physically distance, it amplifies the benefit, it amplifies the protection even more. So I would say each West Virginian has the power today to protect themselves and their family and the state of West Virginia and our vulnerable and our healthcare workers just by wearing a mask and staying physically distanced. It is that simple. And if we do it, and as we talked about, you know, the first thing to do is change yourself. If we can make that commitment to do that, then we'll protect each other. So the first reason why COVID-19 is so infectious is because it spreads by droplets and aerosols, and we produce them all the time. Okay. The second reason why it's so infectious is because at least 50% of the time, and maybe as much as 75% of the time, the disease is spread by people who do not know they have COVID-19. So people are either pre-symptomatic, which is the 2.5 days to the day of symptoms, 2.5 days before to the very first day of symptoms, that time period, or some people can remain relatively asymptomatic through the whole time of COVID-19. And so the second reason why COVID-19 is so infectious is because people don't know they're infectious, they have no symptoms when they're actually spreading COVID-19 to other people. And so that means that you can't just rely on, oh, I feel fine, no problem. You have to basically protect yourself and protect each other all the time. And so that's another problematic issue, because a lot of time we think, hey, we feel okay, so no problem. But in fact, that's not true at all. And 50 to 75% of the time, people who spread COVID-19 have no symptoms at the time they spread it, okay? That's reason number 2 why COVID-19 is so infectious. Reason number 3 why COVID-19 is so infectious, and I could use reason number 4, but let me just, this is the biology, is it appears that there has been a mutation in the spike protein. And remember, COVID-19 coronavirus is named coronavirus because remember, like when we were kids and we drew the sun and we just draw a big circle and color it yellow and we just draw some rays out from the sun with like straight lines. Well, that's coronavirus. The middle part of the coronavirus is like the little fat globule. It's like a little round thing of butter. And then sticking out from it are these protein spikes, which are like those straight lines. And that resembles the corona of the sun, which is the lines that go out from the sun. And those are the spike proteins. And that is where COVID-19 binds to a receptor in our bodies called the angiotensin converting enzyme 2, which is present everywhere. And so that spike protein has mutated, and it appears that that mutation accelerates the ability of COVID-19 to bind in our bodies and get taken up in our cells. It makes COVID-19 a more efficient infector of our body. But the good news is, at least in animals, this mutation of the COVID-19 appears to induce a less severe disease. And we know that while hospitalizations are going up and cases are going up like crazy, the deaths are not going up quite as much. And so that could be part of that reason. And of course, for better treatment and all that. And I'll talk about that in just a second. But the third issue with this is that this spike protein appears to be more susceptible to the vaccine and to some of these antibody treatments than the old spike protein. So that's actually good news as well. If you look at, you know, the fact that this can perhaps infect more efficiently, it still may be better news for us longer term. So those are really the 3 reasons. We make it in droplets, and the droplets can spread around a room and concentrate. And number 2, a lot of times people who infect others infect before they have symptoms. And number 3, the virus has become, at least potentially become, more infectious and more able to infect us. So do we have any questions yet? And I'll keep going if we don't.
Yes,
Yeah.
we actually do, Dr. Marsh.
Clay?
Clay.
Okay.
It looks like we have 2 or more vaccines coming online soon. So can you talk about the challenges of transport and delivery of those vaccines and West Virginia's plan for distribution?
Yes, for sure. So let's talk just a second about the vaccines. And just as a really quick background, there are, I think, 171 different vaccines that are being produced at some level for COVID-19. The top 2 vaccines are actually exactly the same strategy, and it uses a genetic strategy, which is one that we've never really taken before. And just remember, the fastest vaccine that's ever been made in our country from start to finish is the mumps vaccine back in the 50s. And it took 4 years. So you can really see how rapidly we have come to make the vaccine for COVID-19. And the reason why the vaccine has been able to be produced so quickly is, number one, everybody understands that spike protein that I talked about, those corona that go out, the little lines that go out from the center of that round sun or the round virus, is where the target for the vaccines are. And so these vaccines are called messenger RNA vaccines. And those are the Pfizer vaccine and the Moderna vaccine, the 2 that came out. They had very, very good results. And it's basically using a piece of the viral genetic code to put into people and let people produce that spike protein inside of our bodies and then have our immune cells respond to it. And both the Pfizer vaccine and the Moderna vaccine, which basically used exactly the same strategy, the Pfizer vaccine, they broke the code early and they had, I think, 94 people. And in those 94 people, 90% of people who had gotten COVID-19 did not get the vaccine, and only 10% of people that got COVID-19 got the vaccine. So the vaccine, and anything over 75% is a really good vaccine. And some people were thinking, well, maybe it would only be 50% effective, but that 90% was really good. And it was really reassuring that the Moderna vaccine, when they looked at their data, which was, I think, 96 people, their data was even better, where 94% of people who got the vaccine were protected against the virus, and only 4% of people I'm sorry, 96% of people were protected. They were in the group that did not get the vaccine, and only 4% of people had gotten the vaccine. And what was even better about Moderna was that the Moderna vaccine trial, which was 30,000, I think the Pfizer was over 40,000, but included people of ethnicity, people who are more risk, more vulnerable, African Americans, Latinos, Hispanics, Native American Indians, and included older people. And so it appeared that the really severe side effects, which we didn't really know from the Pfizer trial, the really severe side effects were really restricted to people that did not get the vaccine, which was encouraging that maybe the vaccine doesn't just protect you from getting COVID, but if you get it, maybe it protects you from getting really severe consequences of COVID, which is something that was a question from the Pfizer trial. The difference between the Pfizer vaccine and the Moderna vaccine are significant, though, because Pfizer, the vaccine requires ultra cold storage, which basically means you have to store it at about minus 90 degrees. And even the ability to keep it that cold and transport it is really problematic. And part of the vaccine distribution plan with Pfizer is how much dry ice can you get. And once you reconstitute it, it only stays good in the refrigerator for a matter of hours, as opposed to the Moderna vaccine, which only needs minus 20, like a regular freezer in your, in your kitchen, to stay active, and it can be stored for up to 30 days, is my understanding. So if you look at big vaccine places, let's say you have big medical centers, and part of the vaccine trial, of course, is to prioritize how we give the vaccine to begin with. And one of the first groups that are slated, and this is working with the Centers for Disease Control, and this is not like the West Virginia plan, different than everybody else. These plans are all coordinated around the country so that we can make sure that we are consistent with how we are approaching the most important populations. And I think that the decision is to support the healthcare sector as an early immunization group, and perhaps the most highly vulnerable, and perhaps first responders and people that we can't afford to get sick. So as we go forward, if you have a big medical center you're vaccinating, then certainly the Pfizer vaccine or the Moderna vaccine would be acceptable, certainly because you would use a lot of vaccine at one place. If you're transporting vaccine to rural West Virginia, though, that the Pfizer vaccine becomes much more challenging. And so now that we have more than one vaccine, then you could, at least theorize that you may use the different vaccines for different purposes. as we are, immunizing people. And because the US government bought the rights to 100 million doses of the Pfizer vaccine with an option for 500 million more doses, Pfizer didn't take any money from Operation Warp Speed to develop the vaccine. And the Pfizer vaccine is really a German company that created the vaccine. But the Moderna vaccine did receive, I think, $2.5 billion from Operation Warp Speed to develop the vaccine. And therefore, the US has access to 100 million doses of the Pfizer vaccine, as I understand it, 100 million doses of the Moderna vaccine, an option for 500 million more of the Pfizer vaccine. And I'm not sure how many more doses of the Moderna vaccine, but each of these vaccines has to have 2 shots. And by the time the companies individually can produce enough vaccine, say 100 million vials, to be able to immunize populations, then each vaccine will probably only be able to immunize about 15% of our population by probably March or April. So it's very likely that we'll see these vaccines be given well into 2021 and maybe even through 2021. So it really does underscore this idea that we still have to be highly cognizant and diligent about wearing masks and protecting ourselves during this time that the vaccine's being produced. It hasn't gotten emergency use authorization yet, either one from the FDA, but the thought is it will, that both of these vaccines will probably be given the thumbs up by the FDA after they look at all the data, have to see that, but then it has to be manufactured, then it has to be distributed. So I think it's safe to say that the US won't have enough people immunized and immune responsive, which would be 70% for this virus, which would give you herd immunity, as people talked about, until probably mid to late 2021 at the latest.
Okay, Dreama, do you have a question?
I do. So someone wants to know if an infected person has clinically recovered and then later is identified as a contact of another person with COVID-19, do they need to be quarantined again?
That's a really important question. And I think that would really rely on a couple of things. So number one is that we know that although it's really unusual, some people can become reinfected with COVID-19. So I think a lot of that would be related to what is the real exposure and how is there any complicating issues with that person that already been infected. In other words, people who are immunocompromised, who don't have sufficient abilities to mount an immune response, or people that are really elderly or who are really very vulnerable. There's a case report of somebody that got treated for chronic lymphocytic leukemia, which is a disease that affects the immune system and the ability to make antibodies, or say somebody that might have had a splenectomy who lost the ability to make antibodies as well, then they could be susceptible to reinfection. So those people probably should be quarantined and should be watched closely, because if they would get infected, they could get real sick. But I think for the normal person, if you've really documented that somebody had COVID-19 and responded to it, you could always do an antibody test to see if they still had the ability to, have immune response against COVID-19. But those kind of situations probably do require input and insight from local health officers who do a thorough contact tracing and could make a medical decision about that. That would be an unusual circumstance, but maybe one, because COVID is spreading so quickly, that we'll see more in the future.
Okay, I have one coming in. Can you talk a little bit about, hold on, I lost it here. Can you talk a little bit in your medical expertise, is 90% effective of a good rate in regards to a vaccine?
Fantastic rate. It's really, and again, the fact that the Pfizer vaccine came out at 90% effective, I think Moderna was 94, 96. I can't remember off the top of my head. I think it was 94, but either way, those are spectacular. And the fact that they're both based on the same kind of strategy is confirming that that's probably a real result. When you when you stop early and you look at results, you always want to make sure that that really represents what you might see if you go through the whole thing. And I know from the Pfizer vaccine, the full thing was 164 people infected with COVID-19, because in your trial, you have to wait to see who gets infected to see how good the people that were vaccinated were able to fight off COVID versus the people that were vaccinated with just water instead of the vaccine. And so ultimately, you know, it's really promising that you have both companies using the same strategy, getting almost the same results. Yeah, over 90% is phenomenal. That's way better than people would have hoped for. That is really, really, really favorable. And they appear to be pretty safe. Some local pain at the injection site, and some people feel kind of crappy for a day or so because you're kind of mounting an immune response. But in general, the vaccines where there have been more serious side effects were the AstraZeneca vaccine and the Johnson & Johnson vaccine that were on a completely different strategy. They used another kind of viral vector, but it was different. And so it's reassuring that the Moderna and the Pfizer both didn't show very much in the way of side effects, and they both were very effective.
Okay, and following up on that, has there been any additional information in regards to some individuals that I've spoken with? They think that they actually had a COVID-19 back in January, February.
Yeah.
They were tested for the flu, it was negative. And then when the antibody tests started coming online, it was like 3, 4, 5 months down the road before they got the antibody test, and it came back negative. So can you talk about, do you think COVID-19 was here before it was here? and can you talk about the antibody test and how long it stays in your system?
Sure. Let me, I think that's good. I was going to talk about testing a little bit. Let's just talk about testing in general. And the answer is that using really careful genetic studies, it appears, looking at samples, that COVID-19 was probably on the West Coast. That's where it started. And then it went to New York. And then everything on the east side of the country really came from New York City. I mean, that's at least the way a lot of the genetics were. But probably came to California and Washington State as early as January. And some people even think that maybe you could track it back even a little further. Because remember, starting in China, any place that's connected to any other place, and the West Coast is connected to Asia, that when people come back and forth, they bring it with them. So that's really what the community spread is. So there's really 4 ways to look at the COVID, the COVID positivity. 2 ways are genetic, and then 2 ways are protein. And the 2 genetic ways, the one that we use, the genetic test, which is called PCR, which stands for polymerase chain reaction, basically is what all those crime shows, like CSI Miami or CSI or whatever city it is, they work. And basically, it's taking a really small amount of genetic material and it's amplifying it in a very precise way. And that is the best way to test for COVID-19. The downsides of that kind of testing, and these are the nasal swabs, or this is the saliva test. The downside is that if you send it off to reference laboratories like LabCorp or Quest or others, it can take several days to get back, and it's pretty expensive, but it is the most precise. It is the best at detecting very small amounts of COVID-19, and it is, if you have it positive, you should consider that a true positive. There's another kind of strategy that was used by Abbott on the ID Now test, which is a different kind of strategy to amplify genetic material, but fundamentally, that is probably a little bit less precise than the active PCR test, but still is pretty good. So those are the 2 genetic tests. The test that we're seeing more and more that is being used around the state and country are antigen tests. Antigen tests are testing for proteins on the virus itself. And that's the way that we detect if we do a flu swab to get, or a sore throat swab, I mean, for strep, or a nose swab for influenza. That's how that's working. It's identifying proteins on the virus. And that kind of test is is good if done correctly. If you have a positive, it's really a positive, particularly if you have somebody who's symptomatic, but it may miss small amounts of virus. So it's not as good at picking up really small amounts of virus as opposed to the genetic test. And then the last kind of protein test is an antibody test, which is what you asked, Sarah, which is not measuring anything on the virus. The genetic test and the antigen test measure virus stuff. This is measuring the human response against the virus. And it's been challenging to figure out how to use this particular test. Initially, it was thought, as you have suggested, that it would be a good way to say, hey, are people responding to COVID-19? And therefore, that's evidence that you had it and your body remembers it and it's responding. But unfortunately, the test has not been able to document that as well as we would like. And even in places where we know there's a lot of spread, the highest ever amount that I have seen reported is about 23% in small areas of New York City after they just went on fire with COVID in that time back in April or whatever. And in Sweden, that has a country that really never practiced mask wearing or whatever, and they had a lot of COVID spread. They only found 7% of people in Stockholm, their biggest city, their capital, had evidence of infection. So it's not clear to me how well the antibody test will tell us whether you had COVID or not. And it's also interesting that even the best tests, the genetic tests, only are good in a study in the Annals of Internal Medicine about 70% of the time to define COVID-19. So even the best tests are still not 100% able to tell you. And therefore, I think that we all should maintain our actions of protecting ourselves and each other, with mask wearing and physical distancing. Even if you think you've had COVID-19, I would not use that as an excuse to not do the right things as far as taking care of yourself and social, physically distancing. The other thing from the Asian countries that have done so much better, the country of Taiwan, which is 23 million people, has had less than 1,000 total COVID cases and had, I think, less than 10 deaths from COVID this whole time. And they talk about what Japan talks about, which is also avoiding the 3 C's, avoid crowds, avoid closed indoor spaces, and that's particularly important during the winter. And the CDC has reported that if you go to a workplace as opposed to work at home, or you frequent indoor restaurants where people take their mask off, or bars, or coffee shops, or gymnasiums, then your risk of developing COVID is twice as great as if you don't. So we know that closed indoor spaces around other people are problematic, particularly in those environments where people take off their masks to eat or to drink, etc., or to sing, church being another place that we've seen spread for sure. And then the last C is close contact with somebody that you don't live with. And CDC has changed their recommendations. It used to be a 15-minute period uninterrupted, less than 6 feet from somebody who was found ultimately to have COVID-19. Now the CDC says it's 15 minutes cumulatively over a 24-hour period of 6 feet or less contact with somebody who's defined for COVID-19. So it could be 2-minute increments, 12 or 14 times, which will give you the same exposure. So it's really important when you go to places and you don't really know people or you're in gatherings, because most of the spread today is in small social gatherings in people's homes, extended family, friends, where people say, oh, we're all fine, and you get around each other because we don't know who's infected today. And we do know that the infections are growing very rapidly. We've had the highest single number of infections that has been bested on several days, both in the country and in West Virginia. And the country, we're averaging over 150,000 new cases a day. And Tony Fauci thought in the dead of winter, we might get to 100,000. I mean, we're just expanding that so quickly. And in West Virginia, we have seen the highest weekly total that we've ever seen. And it's generally 2 to 4 weeks after you see those increases that you start to see hospitalizations rise. And today in the US, we have more people who have COVID in the hospitals than we've ever seen before. And in many states, you know, ICUs and hospitals are really filling up. In West Virginia, we are also seeing more people in the hospital with COVID than we've ever seen before. But we're very carefully tracking that with all of the hospital systems and CEOs. And so we're starting to look at reducing some of the strain on the hospitals, because most of the people in the hospitals still are people that don't have COVID that are getting treated for whatever they need, surgeries, and we want to provide, you know, the needed care, but we have to be careful about not using our capacity for people who don't absolutely have to be in the hospital right now. So we're working with the hospitals in West Virginia to start to look at a plan to perhaps slowly reduce some of these procedures as we would need to. We're not doing that yet, but as we would need to make sure that we are maintaining an appropriate surplus capacity of hospital beds. And importantly too, we know that, you know, hospital workers, like all of us, we live in communities as well. And therefore it's a two-sided equation. One is how many beds do you have? But the other one is how many workers do you have to be able to take care of those people? And so both of those equations are things that we're watching really closely. But I know a lot of people are getting very nervous because we're talking about hospital beds, and people shouldn't. We still have plenty of hospital capacity in West Virginia. We're fine. But we know that 2 to 4 weeks after we see increases in the numbers of people, we can anticipate seeing more pressure on hospitals and hospital systems. And so we're starting to anticipate that potential rise. Now, the good news is around the holidays, that's a traditionally lower census, lower number of things going on for people in hospitals. So that actually might work out well, because we don't want our hospital systems to start to see that surge like we saw in New York City and other places are seeing now. So it's a very challenging time, and that's the reason why it's so important for each of us to practice that really important service and altruism to each other and to our healthcare systems, to wear your mask and stay physically distanced and avoid the 3 C's and wash your hands and be careful, because this disease is spreading rapidly. And as people go indoors, it's likely going to spread more rapidly. And that's the reason why a lot of people are really projecting that the next, you know, several weeks to perhaps a couple of months is going to be very, very challenging for the US and for the world, because as people go inside and the humidity in the air gets less, that makes COVID more easy to stay airborne, to infect other people, and we're already seeing that cycle starting. You're muted, Sarah.
Okay, we'll go to Dreama for the next question.
Okay, this is going to take you back to the vaccines, but you stated that both of them require 2 shots. So how far apart are those shots, and how much protection do you have after the first shot before you get the second one?
So I don't know the answer to the second part of your question. To get the appropriate sort of antibody levels, both of these companies determine that you need 2 shots to get the maximal. You probably do get some protection with the first shot, but certainly both shots, like a hepatitis series, like we need, you know, boosters on that as well. So we'll need that, and we'll likely need these shots every year until COVID becomes more of a you know, less problematic thing for us, which it likely will over time. I think most people believe, and the distance between the shots or the time is about 2 weeks.
Thank you.
So we have time for a couple more questions, and one, obviously, what are you doing for Thanksgiving, and what do you recommend West Virginians to do for Thanksgiving?
Yeah, so we're going to have Thanksgiving just with our immediate family. Now, my son goes to school in Chicago, Illinois, and Chicago just had a mandatory stay at home on Monday. So he quarantined for 14 days before I went to pick him up, and he got a PCR test as well before we picked him up, which was negative. Our daughter is a first-year medical graduate who's working in the hospital, and she works with full PPE, et cetera. But she as well will quarantine for 5 days before we all get together and get probably a rapid test, even though that's not absolutely protective. It's helpful. And then our middle child is a computer engineer who works from home, so he's okay. And my wife's been at home. So we're just going to basically have a family Thanksgiving dinner, and we will call my mom, who's the only living parent my wife and I has, and the people that are close to us. And I think for people in West Virginia, the thing that's so important, and the other thing is, even though we've been around each other as a family, some during this COVID pandemic, it's really important that if you haven't really been around each other, or people aren't able to quarantine or get a test, then try to prevent vulnerable people from attending any kind of an indoor gathering with others, particularly if masks won't be worn. I think that if you want to visit extended family, and maybe instead of having a big Thanksgiving dinner inside, maybe there's an opportunity for people to sit outside with each other for a little bit, and outside is massively safer than inside. And if you have to be inside, perhaps having windows open would be important to consider, just to get additional airflow from the outside, because the more air that you have exchanging, the less those droplets and aerosols kind of stagnate in the environment that you're in. And outside's even better than inside. And if you're going to go visit people, and let's say that you have to be inside, I would say, stay physically distanced, have everybody wear masks, and don't eat together, just socialize for a little bit, and then go back to your smaller pods, and then have, Thanksgiving dinner or lunch or whatever you decide to do, in a very small group of people that are together as your nuclear family. The more people around each other who are from the standpoint of trying to keep everybody together. I mean, we know that masks and physical distancing are the two most important powers that we have right now to keep COVID from spreading. And they're really effective. I mean, if people do it, and we see again, these Asian countries, the death rate in the US per million population, I think is 686 people. The death rate in Thailand per million population is 0.36% people. So it's just a dramatic difference when people do wear masks, and we can do these other things. So I would say that it would be, in the health standpoint, an appropriate medical, move to do, to require masks indoors in all environments, and really reduce that, take a mask off in any environment where you're not protected. I do think, though, that would start just like the seatbelt laws did, just like the mask laws did in 1918, the anti-mask league, people feeling that that's an infringement upon their personal and constitutional rights, et cetera. So I think that we just have to be careful about not creating a big divide between the people that feel that that's a good thing to do and the people that feel like that's infringing upon their personal rights. And I think the more we can get people to do this cooperatively and really play on their better angels of not just protecting yourself, but really protecting the people that you love in your community, and trying to protect our healthcare workers, because we know that in hospitals and in healthcare, places, when you get overwhelmed with COVID, whether it's because you don't have enough beds or enough people to take care of the folks in the beds or both, then everything starts to get worse. So your ability to take care of heart attacks and strokes and infections and all that gets worse because people are overwhelmed and the healthcare workers are getting sick themselves. And so the real big opportunity for us, our 4 legs of our stool are aggressive testing, and we've done that. Aggressive contact tracing so that we can identify the people who are infected and separate them. Aggressive mitigation, which is mask and physical distancing, avoiding the 3 C's, but also vaccine and vaccine distribution. And then the 4th one is protect the healthcare assets, because when the healthcare assets get overwhelmed, we know things get much worse for everything. And so that's really the 4 cornerstones of our approach and strategy in West Virginia right now. But it really does ultimately depend on the willingness and the commitment of each person in our state to answer that higher calling to, to serve and to help each other and to create a safe environment so that COVID can't spread. And we've done really well so far, relatively speaking, but it's going to be the most challenging time coming up, without a question in my mind. You're muted, Sarah.
We'll end on this question here, because you mentioned contact tracing. And so is there a certain point we get too high on the numbers that contact tracing doesn't help? I mean, do we need like a 2-week lockdown so that it can die out a little bit and then we can pick up on contact tracing? I mean, how does that work?
Yeah, that's a really important and great question. So the more new people you have, the more rapidly, the harder it is to keep up with contact tracing. So we are already moving to some different strategies. There's a few out there that I think are really exciting. So there are apps that can be used. Now, many people don't like to do that because it, again, some people feel like it infringes upon their personal rights. But those apps can basically Bluetooth connectivity tell you who was close to somebody if they were ultimately diagnosed with COVID-19. And so that's an electronic contact tracing app that can work well. Second issue is clustering, which I'm a particular fan of. And what you do is you trace back again. So we know that 70% of people that get diagnosed with COVID-19 infect nobody else, and 5 to 10% of people infect 80% of others. So when you see a cluster, when you see somebody who's positive that's connected to other people that are positive, those are the areas you really want to contact trace. So we might use that as a way to prioritize where we put our assets. And then the last thing which we have done is we have a cloud-based system of reporting for EPI in West Virginia. And ultimately, then we can bring in outside contact tracers over the web. And there are professional agencies that also do this that we're looking into contracting with. And we have a lot of people who volunteered to be trained at the universities and the health science schools, et cetera. Hey, I got to jump too. I've got another thing coming. Thank you, guys. Thank you for everything you do. Have a great conference.
Well, thank you so much.
Hey,
And wow, what a great segment here. So we appreciate Dr. Marsh, and we appreciate Dr. Mace and Dr. Nemitz for joining us all this morning. And we will continue our program now. And with our next group of speakers, I would like to ask Elaine Miller to introduce our next 2 speakers. Elaine Miller is the State Director for AARP West Virginia. And AARP is a supporter of this conference. They're a supporter of our communities. And so welcome, Elaine, and so glad you can make it.
Thank you, Sarah. I want to thank the Alliance for Economic Development of Southern West Virginia and the West Virginia Community Development Hub and the Coalfield Development teams for the opportunity to be with you all here today and participate in this important conversation. Joining me are 2 of my esteemed AARP colleagues to discuss how the use of evidence-based data influences and supports AARP's health advocacy efforts at both the national and state level. And if you haven't already, I encourage you to take a few minutes to check out their bios on the conference website. As you will see, their credentials are very impressive. So now, without further ado, please join me in giving a warm Mountain State welcome to Dr. Susan Reinhard, who is the Senior Vice President of the AARP Public Policy Institute, and Ms. Elaine Ryan, who is AARP's Vice President for State Advocacy and Strategy Integration, as we like to refer to it at AARP as SASI. So join me in welcoming these fine ladies.
Thank you, Gayleen. And I also want to note that Paul Lingenfelter is on and he's going to help us with the presentation. So Paul, you could get us started. It's not a lot of PowerPoints, but there's data and that's always hard to talk about without some reference. So you can go to the next one, Paul. So this is what we wanted to talk about. I could listen to Dr. Marsh, the Czar, all day. He was just fantastic, just excellent. And just a couple of points. He certainly talked about the high community spread, the challenges going forward. But I don't think we talked much, or maybe I missed it, about how 40% of the people who have died from COVID have been in nursing homes and or assisted living, 40%. So Kaiser is talking about, that's a data source, talking about over 90,000 people who have died in nursing homes, assisted living, and other long-term care facilities. And there's a great interest in living in their homes and communities, always has been. Always. We know that all our data at AARP has shown that people prefer to live at home if they possibly can and be with their families. Not just at Thanksgiving, but all the time. And so we have two tools that really go together, we think, to help have a conversation about policy in West Virginia and across the country. So the first is what we call the Long-Term Services and Supports, LTSS State Scorecard. I'm just going to go over that. That particular it's a very complex scorecard that we've been doing since 2011, every 3 years. And it has more of a focus on home and community-based services. Lots of data, I'm going to talk about that, hopefully not bore you, but it doesn't get into COVID. It doesn't get into the data is collected before COVID, and it hasn't been talking certainly about what's been going on at that level. So we just created what we call the nursing home dashboard. And the nursing home dashboard does give that information for every state. We just launched it last month. We just had the second release this month, which shows some change since October's release, and we're going to do it every month. So putting those two things together, those two tools, we hope can lead to looking at some promising practices and potential policy solutions for you in West Virginia, and hopefully we'll have some time for questions and answers. So next slide. So this is what the scorecard looks like. That's the picture, the cover of it. It's been going on, as I said. It has lots of indicators I'll talk about in a minute, but we thought we would talk about the two new ones. It's just about adult day and also more on home and community-based services. That's what SCBS is, on quality. And we've replaced a couple of them. So next slide. If you can get to the next slide, Paul. So this is a complicated slide. It is available to you if you're interested, but I just want to give you a high-level view of this. What we've been doing is, since 2011, is talking about what would a fantastic long-term care or LTSS system look like? What is the vision of this, a high-performing system? And we have definitions of this, and we also have 5 areas, we call them dimensions, each one of which has lots of different data. So altogether, we have 26 separate indicators for every state to look at how they're doing. And we track it over time since 2011. So there's a lot going on here. If you just look at the top level there, it's, you know, ideally, you would have access to the services that you want in long-term care, and you could afford it. That would be nirvana, I call it, right? And you would have choices. It wouldn't just mean a nursing home. There'd be lots of different options for you. And by the way, you could find these things. Then quality of life and quality of care. It's employment for people with disabilities is a very high mark for quality of life. And we get into a little bit of nursing homes and a little bit of home and community-based services kind of data. And then a big one, a big dimension equal to all the others, is support for family caregivers. And I know my colleague Elaine is going to talk a little bit about that too, with how West Virginia has been doing. But it's supporting working family caregivers. It's making sure that family caregivers are part of a person and family team with professionals and other issues, including transportation, by the way. And then effective transitions means that you don't get bounced around. You don't go from home care back to the hospital, nursing homes to the hospital. Heavens knows right now that is not what we would like to see. And especially if you have dementia, this is really what we call a burdensome transition, particularly at the end of life. And there should be ways to get back into the community if that's what you want to do. So successful discharge to the community. So that's a very high level of all of what is in the scorecards. Next. So looking at West Virginia, I just wanted to point out a few things that West Virginia, which scores at overall, not great, but improving in some areas, like PWE is persons with disabilities with Medicaid. So in other words, West Virginia safety net has improved. We call it a Medicaid safety net, has improved, ranking at about 30 now, that 37 people out of 100 of those in West Virginia that have needs, long-term care needs, get Medicaid if they need it. So you've improved in that in the last 3 years. Nursing home antipsychotic use. This is, we used to be very concerned about people being physically restrained in nursing homes. And then we started looking, and that got better. Now we've been looking at chemical restraints. So, let's not give you some antipsychotic. That's a very strong medication that should be given only if you have diagnosed psychosis like schizophrenia. But you shouldn't be getting those medications if you don't have those diagnoses, just so that we would keep you calmer, so to speak. So we've been tracking that over time, and you are 18th in the country, which is a good thing. You have improved in that area in the country. And then in person and family-centered care, you're ranking about 21 and have improved in assessing family caregivers, asking them how they're doing, for example. And in something known as the CARE Act, which my colleague Elaine and I have been very involved, and I'll let her explain more about that because I think that's a very exciting area that you have improved in. But then declining in 3 areas, the spending, we call it Medicaid balance. So most states years ago spent most of their dollars, their Medicaid dollars, public spending on nursing home care. So people didn't have much of a choice, and the dollars were spent in nursing homes. Then in the last several years, probably actually 20 years, but definitely getting better, spending more money, allowing people to get services in their homes and community settings. So you had been doing a little better, have gone down. You were at about 30% of those of spending went into home and community-based services. It is now down to about 26%. So that's definitely an area to look, particularly with COVID, that you would want to make sure that if you're spending public dollars, that you're spending it where people want to be, and frankly, where it's safer to be. Nursing home costs, of course, nursing homes are costly everywhere. It got costlier in West Virginia than perhaps in some other states. And long-term care insurance is a private policy for long-term care. That is going down everywhere. So I wouldn't feel too bad about that. It's a market that needs major improvement. And there's a couple of states that are really leading the way in that. So plenty of room for more improvement. Next slide. So this is the nursing home dashboard that we released, the one we just released last week. And it's a lot, I know, but there's a lot of data. AARP has been pushing, and others have been pushing to get better data around what's going on in nursing homes with COVID. And gradually it's gotten better. In May, the federal government required nursing homes to report their resident cases, resident is a nursing home resident, cases, how many people have died, how many staff have cases and staff deaths. PPE is personal protective equipment like masks and gowns and gloves that you really need. There's actually 5 different PPE types that we put under supply. And staff shortages. Do you have the staff that you need? You just heard Dr. Marsh talking about that. It's not just beds, it's people to be able to care for you, whether you're in a hospital or a nursing home or home care. Staff shortages is a problem. So there's lots of other data that the states are reporting. Some states reported even before this, but by May they had to. And so we have tried to make this more simple. It's very complicated data. This is all publicly reported. And there you have link to how you can get this, but you can get this. It's just incredibly tedious to go through it and understand it. So we have tried to simplify this, focus in on those particular areas. We do provide some other data, but those are the ones we're tracking right now. We're going to change this over time. We'll add to this. We'll look at assisted living more. We desperately need data on multicultural issues. Race and ethnicity is not well tracked right now. So we don't have that right now, but those are the areas we are looking at. So I don't think you can see it too well, but there are deaths. On the top are the deaths and cases of nursing home residents, and on the bottom shows the PPE and staff shortages. So I've got a little bit there that in terms of resident cases and deaths, about average. The red is West Virginia, the blue dotted is the national. So West Virginia is tracking. Now, these are only 3 data points. We went back into August to look at this, but tracking pretty much closely to the national average. But if you look at the bottom ones, that you're outperforming or doing better than the national average in PPE and the protective equipment supply. At least, remember, this is all self-reported data by nursing homes. This is what they are reporting. So this is what your nursing homes in West Virginia are saying. They're saying that they have at least 1 week's supply, not all of them, of course, but they're doing that. You're doing better than the national average. On the other, so far, on the other hand, underperforming in staffing. So you can see that red line lower than the blue dotted line under staffing, meaning that you have more severe shortages than the national average, again, as nursing homes are reporting. So that's just a quick look at that's why we call it a dashboard, right? It's a really quick look, but again, we'll keep looking at this. And by December, we'll have this on a website that will become more interactive and even easier to use. So next slide. Okay, so I'm going to turn this over to my colleague, Elaine Ryan, who's going to talk about the state advocacy before and during the COVID pandemic, some of which has been involved in looking at these data, having conversations. Elaine, we certainly need to give you a shout out and trying to help West Virginia citizens and policymakers have conversations about this. So I always say the Public Policy Institute at AARP is here to serve. We're serving you up data, evidence, and it's really up to you to do something with it. So let me turn over to Elaine.
Thanks, Susan, and good morning, everyone. I was thinking about the earlier presentation and just the historic time that we're in. You know, Susan has gone through the long-term services and support scorecard. She pioneered this tool that has been used by states across the country to not only see where they are, but to use it as a tool to improve where they are. And I too want to acknowledge Elaine Miller and her extraordinary leadership in West Virginia for our AARP office in looking forward. And what I just want to cover today are really 2 sections. One is kind of the things that West Virginia has done and plans to do in response to the scorecard, and then a look at the nursing home crisis that we're experiencing across the country. So first, as Susan noted, one of the categories for the long-term services and support scorecard is support for family caregivers. And I've been so impressed with the progress that our state offices have been making across the country. Since we started our advocacy in 2014, over 400 new laws have been enacted in every single state and territory across the country. West Virginia was an early leader in support for family caregivers. And one clear improvement was the enactment of the CARE Act, the Caregiver Advise, Record, and Enable Act. And what it does is simply this. It recognizes that family caregivers are an integral part of the health team. No one has to tell West Virginians about how important families are in supporting the needs of their loved ones at home. And as Susan mentioned, 90% of people tell us at AARP they want to age in their own homes and communities. But we also know that that means that families are often at the front lines of healthcare after a loved one has exited a healthcare facility. So what the CARE Act does is it establishes that when someone is admitted into the hospital, someone of any age, the name of the family caregiver is recorded in the hospital file. Secondly, during that stay in the hospital, families are advised as to the discharge plan, but even more, some of the things that they'll be asked to do post-discharge. And then finally, at discharge, families are given an instruction of the medical tasks that they would be asked to perform on behalf of their loved ones. I know it's not a surprise to anyone who has family or been a family caregiver. I, for one, was a family caregiver for my mom and pop for about 15 years. I learned to master the nebulizer. By the way, I have no medical background. That's not unlike many family caregivers in this country. So that idea of giving someone a simple instruction of those medical tasks is essential, really, to prevent for rehospitalizations. The second thing that West Virginia did early on, and again, a leadership of many organizations under the leadership, I'd say, of AARP West Virginia, West Virginia expanded scope of practice. That is allowing nurses and health professionals to perform up to the full extent of their education and training. Hard to believe that while nurses were trained and capable of doing many things, state laws prevent them from doing so. Now, I wouldn't say West Virginia was the first, but I will say that in the race for best state, just to say years ago, West Virginia enacted scope of practice changes. This year was the first year California ever did it. And so what that means, though, is that it empowers the workforce we have. And as you may know, that during the COVID crisis, this has become just increasingly important, as even the federal government have waived federal rules to allow states to have expedited scope of practice rules in an expansion of those medical tasks. So key in terms of serving our healthcare systems and our loved ones. Also, AARP West Virginia, as many of our state offices, have extended telehealth services. There has been progress made. There's a long way to go to making sure that we have telehealth that is sophisticated, accessible for all. And that takes me to experiences that Susan and I were having earlier today, which is the fickleness of our broadband services across the country. Rural America clearly suffers from not only cost, but access to broadband services. So in order to realize the full potential, not only for hospital providers, for long-term care facilities, for individuals, broadband needs to be expanded. I know also Elaine and her team are committed to expanding home and community-based services. It'll come as no surprise when you consider the COVID pandemic that people who receive care in their own home actually have had lower rates of infection, fewer deaths in home care settings. We also know that it's important for us to modernize our outdated federal laws that would enable more states to do more. You know that we give states open-ended funding unlimited funding to care for someone in a nursing home, but limited capped funding to care for them at home. Hopefully we can make real progress in the coming years to change that dynamic. I do want to say a word here about the nursing home dashboard that Susan mentioned. You know, in March, AARP started our advocacy across the country to really raise the flag of the increasing deaths to individuals in nursing homes. To date, 91,500 people living in long-term care facilities in this country have died of COVID. It is an outrageous and extraordinary number. We also know that more than 600,000 residents of nursing homes have contracted COVID. Nursing homes are very much vulnerable to the pandemic. And it's not only the residents, but it is the staff. And in fact, just recent release of some analysis showed that deaths to staff members working in nursing homes have exceeded over 1,000 lives lost of frontline staff in those facilities. And so AARP has been working in states across the country to try to get states resources to be able to fight COVID in these nursing home settings. We are working in states across the country to enhance PPE, to enhance testing. And I do want to acknowledge West Virginia for announcing once again that they intended to test nursing home staff for COVID prior to their working in these facilities, and to do so twice a week. You know, I will have to say West Virginia is far ahead of other states who aren't testing at all. And so it takes courage and it incurs cost in time to do everything we can to protect our most vulnerable citizens in these settings. And a sincere word of thanks to West Virginia for its leadership in this area. But we are in a crisis of increased COVID cases, increased hospitalizations, increased deaths in nursing homes. And I do want to point out that AARP is working not only in states across the country, but in Congress to try to get more help. We need to raise the flag that this is a crisis. We also need to acknowledge the states that are working to enact new laws during the pandemic. Oklahoma, for example, recently enacted a law on staffing standards to ensure there's adequate staffing in nursing homes. South Carolina governor issued an executive order that required some visitation plan for people who are living in nursing homes, who have been shut out from any visitation of their loved ones for nearly 9 months now. Social isolation is inextricably tied to deterioration in health status. So making that connection, making sure there's a plan, making sure there's ongoing communication is essential. And while some of this cannot be done in person, AARP is fighting in states across the country to use virtual visitation as a stopgap approach to ensure a safe connection with loved ones who are so dear to us. I just want to say in closing that we want to be upbeat. And so taking the instruction of our introduction here, I do want to say that even at times of crisis, states are finding ways to move forward to meet the demands of this pandemic. And AARP stands ready to advocate with you to get the supports, the education, the tools that are needed so that we can all see a better day in this country at this unprecedented historic time. So thanks, Susan, and thanks so much for the opportunity to share those thoughts.
Thanks. And I need to correct something, Paul, if you could put the slide back. I was having trouble seeing your data. So you're outperforming in PPE supply and underperforming in staffing. Is that what I said? I just want to make sure I read this correctly, but
Yeah,
there's
you
the data. Okay,
Yeah,
thank you.
Thanks, Susan. Thanks, Elaine. Sarah, is there any opportunity for Q&A, or do we need to move on?
I think it's time to move on, but what a powerful presentation, the scorecard and the other link, the dashboard, we put those links directly in the chat section. So you should have those as a resource. And we just appreciate Elaine and Susan and Galen very much for this powerful program. And we've learned a lot, and it's a lot of data. But, you know, it helps ground us on where we need to work moving forward and what we need to do. So thank you, ladies, very much for the opportunity today. We appreciate it very much.
Thank you. Thanks, Elaine. Thanks, Susan. Thanks, Sarah.
Thank you. Bye-bye.
Bye.
So next on our program, I'm going to turn it over to the project coordinator for the West Virginia Collegiate Recovery Network, which is a project of the Alliance for the Economic Development of Southern West Virginia. Our coordinator, Susie Mullins, she does a great job, and she works diligently every day to help those in recovery and connect them with services and support. And we appreciate you very much, Susie, and you're a wealth of knowledge. You have wonderful resources nationally, and you can get us started with the introduction of the next speaker. So thank you.
Thank you, Sarah. Gosh, I'm a little emotional. So I would like to introduce Dr. John Kelly, and I have to say this is a highlight of my career to be able to introduce him. I know that he was on a session at another conference in West Virginia last week, but we are especially grateful to have him to speak to everybody today about stigma and social determinants of remission and recovery. So Dr. John Kelly is the Elizabeth R. Spallin Professor of Psychiatry and Addiction Medicine at Harvard Medical School, the first endowed professor in addiction medicine at Harvard. He's also the founder and director of Recovery Research Institute at Massachusetts General Hospital and the associate director of the Center for Addiction Medicine at MGH. Dr. Kelly is the former president of the American Psychological Association Society of Addiction Psychology. He has served as a consultant to U.S. federal agencies and non-federal institutions, as well as foreign governments and the United Nations. Dr. Kelly has published over 200 peer-reviewed articles, reviews, chapters, and books in the field of addiction medicine, and was an author on the U.S. Surgeon General's report on alcohol, drugs, and health. So we thank you very much, Dr. Kelly, for joining us today, and I'm really looking forward to your talk.
Susan, thanks so much. Can you hear me okay?
Yes.
Terrific. It was such a nice, kind introduction. Thank you. I'm delighted to be here. Thanks for the opportunity and the invitation. Now, how do I advance my slides? Do I just do it myself? Right. Okay. All right. I just want to say I'm delighted to be here, and thank you for the opportunity and the very kind invitation and introduction. So I'm going to talk today about an issue which, of course, pervades drug use, alcohol and drug use universally, not just in this country, but all around the world. I'll talk about that and how we might be able to address it, because these issues of stigma and discrimination, of course, have major implications, both in terms of access to treatment, as well as staying in treatment and in terms of recovery. So next slide. So I don't have any conflicts. Those are my disclosures. Next slide. So I've been reflecting, it's 50 years, believe it or not, 50 years since the declaration of the war on drugs under Nixon, So given this 50-year kind of milestone, I've been reflecting a little bit on kind of how far we've come in the last 50 years. Remember, there was this concerted effort as a part of the, quote, war on drugs under Nixon to address these endemic problems related to alcohol, but also to illicit drugs, notably opioids, particularly at that time with Vietnam veterans coming back with the threat, the perceived threat of many, many people being addicted to opioids that they were exposed to in Vietnam. So that was part of the impetus of that. But of course, it founded at that time, founded National Institute of Alcohol Abuse and Alcoholism. A few years later, NIDA, as well as other institutes. But when we think about, how far we've come a long way in terms of understanding about the etiology of addiction, its epidemiology, the typology, the phenomenology, the clinical course, treatment, and recovery from addiction. We've learned a lot. We've also learned a lot in relation to that about stigma. Next slide. And we've moved a lot, I think, in terms of our understanding and our rhetoric. If you think about the war on drugs, the rhetoric itself of that term, the war on drugs, implies a kind of militaristic approach, that it could be defeated in a kind of a militaristic fashion. I think when Nixon described drug abuse, quote unquote, as public enemy #1, that kind of language is clear that it fits with that same vein of a kind of a militaristic approach or a war approach. I think nowadays we wouldn't describe it as public enemy #1, but we consider it instead as our top public health problem, which of course it is in this country and most middle and high income countries all around the world. Next slide, please. And our laws reflect that. If you look at the laws that have been passed over the last 50 years, the initial laws passed under that administration and later on under Bush Senior and Reagan, which looked at really harsh penalties, mandatory minimum sentences, which disproportionately affected minorities, for example, with the Anti-Drug Abuse Act, towards later laws which addressed not supply reduction so much, or the threat of supply reduction, but demand reduction and increasing access to treatment. And those took the shape of the Mental Health Parity and Addiction Equity Act, as well as the Affordable Care Act, which necessitated coverage for substance use disorder as a essential benefit. Next slide. And this just shows again what I've just said there in terms of the more recent laws that have been passed, which really are addressing public health issues related to addiction as opposed to punishment. Next slide. I think these approaches were more recently underscored. This was the first ever drug policy reform summit held at the White House back in 2013. And I had the good fortune to be there, and I was presenting actually some data which I'm going to present to you today that related to stigma and discrimination around drug problems. But this really underscored a federal shift away from the rhetoric of the war on drugs towards broader public health approaches. Next slide. And interestingly, this is happening not just here in the United States, but in many other countries. I was actually at the United Nations in January, representing the US, looking at this issue of stigma and discrimination worldwide. But I stumbled across this monument outside the United Nations building. This is not just the Office of Drugs and Crime, but that's the United Nations, you can see there. But what was interesting was this was the only monument outside, and it says dedicated to all those affected by drug problems worldwide. Drug problems are preventable and treatable. So that struck me as really remarkable, in that of all the issues that United Nations deals with, this one had a monument to it outside. And I thought that was testament, indicative of kind of where we're at in terms of addressing these pervasive endemic problems internationally. Next slide. Our approach here in the United States, of course, has changed shape. There are now drug courts, so not just punitive measures taken to lock people up with mental health and addiction problems, but to actually use the leverage of the criminal justice system to help people get the treatment than they need that may be driving the crime or criminal behavior. Next slide. And you may have heard of this fellow. This is Chief Campanello. He's actually here in Massachusetts, in Gloucester. He made national headline news by recognizing that drug problems, that we couldn't arrest our way out of drug problems, that people coming to the station, to the police station, instead of being arrested, were given treatment. And this was Chief Campanello's idea, the idea that we need to help them, not handcuff them. And the idea was to make sure that people with drug problems got treatment rather than punishment. And this, of course, has taken off all around the country now and reflects a remarkable shift, if you ask me, in terms of law enforcement, right at the front line, recognizing a need for treatment rather than punishment. Next slide. So, of course, this shift reflects these issues of stigma and discrimination, which I'm going to talk about. So what is stigma? Stigma is an attribute, behavior, or condition that is socially discrediting. What is discrimination? Next slide. Discrimination is the unfair treatment of individuals with that particular stigmatized condition or problem. Next slide. And this can take many different forms. It can take public forms as well as personal in terms of its consequences. So, of course, public stigma in relation to drug and alcohol problems can lead to different support for different policies, whether we spend more money on building prisons, for example, for people who break the laws related to drugs, or whether we devote more resources to prevention, treatment, and recovery support services. In terms of personal consequences of stigma, it can reduce, as I mentioned, it can reduce help seeking, it can reduce engagement in treatment, it can lead to increased rates of dropping out of treatment. In part, it's related to that issue of shame and guilt, lowered self-esteem. I should be able to control this, but I cannot. Next slide. And these are the commonly studied dimensions of stigma. When we look at stigma and how best to examine it, we usually look at these dimensions of blame. That has to do, are they responsible for causing the particular socially discrediting problem or condition? We tend to have more stigma associated with more personal responsibility for causing the condition. Prognostic pessimism is another dimension. Will they ever recover? Can they be quote unquote normal and trustworthy? And then social distance and dangerousness go together. So when people are perceived as dangerous, unpredictable, there's usually increased social distance, whereby people would not want to have them as an employee or as a neighbor or marry into their family or have them be a babysitter. Next slide. So it turns out, and I've already alluded to this, that when we talk about drugs and alcohol, we are talking about probably the most stigmatized conditions across most societies. This was a study done by the World Health Organization about 20 years ago now, across 14 different countries, 18 of the most stigmatized conditions. This included being a criminal, being HIV positive, having AIDS, as well as being addicted to illicit drugs and to alcohol, the domesticated drug. And interestingly, illicit drug was uniformly the top, illicit drug addiction uniformly the top most stigmatized condition across these different societies. Alcohol was ranked number 4 out of these 18 different conditions. Next slide. Now, what we know from the research is that substance use disorder is certainly very stigmatized, as you can see, but it's actually the most stigmatized of all psychiatric conditions. So it's kind of bottom of the barrel when it comes to stigma and discrimination. We've also learned that compared to other psychiatric disorders, people with substance use disorder are perceived as more to blame for their condition. You can see why. Is that it involves initially taking a substance into your body. Okay, now there's certain genetic factors which influence what happens next, of course. We've learned a lot about that in the last 50 years, but certainly objectively, when you consider other psychiatric illnesses, this requires taking something from the outside and putting it in your body, and that involves choice. And that can be perceived as kind of selfish self-indulgence, and that's where part of the stigma comes from, especially at the expense of others. Describing substance use disorders as treatable helps. It does tend to reduce stigma. We've also learned that patients themselves who hold more stigmatizing beliefs about substance use disorder are less likely to seek treatment, as I mentioned, and to discontinue sooner, they drop out sooner. And also, clinicians are susceptible to holding these same kinds of prejudices and biases that the general public holds related to substance use disorder. In systematic reviews of studies that have been done with clinicians, they've been found to view patients with substance use disorders as unmotivated, manipulative, and dishonest, terms that we wouldn't apply to any other kind of disorder. Next slide. So why is addiction so stigmatized compared to other social problems and health conditions and other mental illnesses? Well, I've already alluded to that a little bit, but next slide. I think part of it has to do with these two dimensions of cause and controllability. And this has to do with blame. So if we can say that a condition or a problem that may be stigmatized is not their fault and they can't help it, stigma tends to increase. If, on the other hand, we say, wait a minute, it is their fault and really they can help it, they really can control it, stigma tends to increase. Next slide. And this just shows these two dimensions and how they're related to the extent of stigma. Next slide. Now, it's interesting when we think about stigma and discrimination, and this is where I think education can help and has helped in terms of our understanding during the last 50 years of lots of genetics research. We know that a substance use disorder's addiction has a very strong genetic component. Roughly half the risk for conferring a substance use disorder is conferred by genetics. And people don't realize when they're first exposed to a drug that they are getting a greater reward, or that they're because of that, they tend to pay attention much more to that experience and are much more likely to repeat it. They just get a more profound effect of pleasure from the same exposure. And this, of course, leads to that increased likelihood of exposure, which can then alter brain chemistry and structure, which can, of course, is indicative of addiction. Next slide. We also know, in terms of controllability, we've learned a lot from the neuroscience, how the neurocircuitry of reward, memory, motivation, impulse control, and judgment shown here are radically impaired when it comes to chronic exposure to drugs. These neurocircuits involve, of course, and they help us inhibit our response to the impulse to use a drug. And people who have had more chronic exposure have impaired neurocircuitry, which prevents them from following through on that decision to use a substance. Of course, we do know that one of the essential features of substance use disorder itself is the inability to stop despite harmful consequences. This is why it is a psychiatric disorder. Next slide. Not just functionally, we can see structurally now through imaging. You don't have to look very long or very hard to see on the bottom right here just how the brain of somebody who is chronically exposed to alcohol, in this instance, how the structure of the brain, not just the function of the brain, is radically changed in terms of the ventricular enlargement and the cortical shrinkage shown here, both through neuroadaptation and cellular death from exposure. Next slide. And when we see slides like that, you know, it helps us understand a little bit why it is would somebody literally poison themselves to death, roughly 30 years on average, earlier than Mother Nature would have intended. And it's because the brain is so radically impaired and affected in a dose-response fashion as a function of exposure. So what can we do about stigma? We've learned a lot about cause and controllability in terms of genetics, in terms of neuroscience. So educating people about that, it can help for sure. There are other ways that we can address stigma and discrimination. Another way is through social exposure, personal witness, putting a face and a voice in recovery, so that we can meet people who have experienced these conditions and that have successfully recovered, and that can disabuse and dismantle stereotypes that we may have about individuals who've had these problems. We can also change our language and terminology, and I'll talk more about that. Next slide. Now, it's interesting, next slide. It's interesting when we look at the educational components and literature there, because it's not as straightforward as we would like. So a question is, if we were to emphasize the biomedical components of substance use disorder and talk about what I've talked about, would we reduce stigma? Well, the answer is yes and no. Next slide. Turns out, these are studies done in mental health. This is 28 studies. This is a quantitative summary of 28 studies which looked at mental health conditions in which they emphasized the biogenetic, so the genetic component contributing to the onset of mental illnesses. Of course, we know mental illnesses, like substance use disorder, has a strong genetic component. Interestingly, what they found was that it did reduce blame. It reduced blame, personal blame, that stigma related to blame, but it increased social distance stigma, perceived dangerousness, and prognostic pessimism. People thought that you couldn't recover, couldn't get well from an illness that had a strong genetic component. Next slide. Also, in terms of the neurobiology, so not just genetics, but neurobiology. So genetics are to cause and neurobiology are to controllability. What about if we were to emphasize the neurobiological aspects, the fact that the neurocircuitry and structural aspects of the brain are changed as a function of exposure, as I mentioned? Well, it turns out that when we talk about emphasizing mental illnesses, not SUD, that it didn't actually do anything to blame, and it increased stigma around social distance, dangerousness, and prognostic pessimism. So kind of contrary to what we would like and hope, when we think about, wait a minute, aren't we going to educate people? Well, what about specifically around substance use disorder? Next slide. We just finished this national study, which was just published in Addiction, just came out 2 days ago, in which we looked at the same kinds of dimensions of stigma and describing a substance use disorder in different ways. Next slide. And we described it in one of 6 different ways, emphasizing the more biomedical emphasis, as opposed to the more generic emphasis. So we called it either a chronically relapsing brain disease, a disease, an illness disorder, or a problem. And we had a vignette that had one of these terms embedded describing someone with drug-related impairment. And it was randomly assigned to 3,600 members of the general US population. What did we find? Next slide. Next slide. So very interestingly, and similar to the studies in mental health, what we found was when you emphasize the biomedical nature of substance use disorder, you do actually decrease stigma regarding blame. So similar to those studies in mental health. But here's the kicker. Interestingly, you also decrease the perceptions that that person can recover. So if we were to refer, for example, which we often do, and people do, and NIDA does, as addiction being a chronically relapsing brain disease, on the one hand, that reduces personal blame, but it also reduces the likelihood, the perceptions that people can get well from a chronically relapsing brain disease. And it also increases other kinds of stigma, perceived dangerousness, and greater social distance. So it's a mixed picture. It looks like there's no one perfect term that we can use in all cases when we're describing these conditions or people who suffer from them, but rather we might need to choose our particular term depending on the kind of communication that we want to project. Next slide. I think it also emphasizes that we don't want to end the sentence with this is a chronically relapsing brain disease or a brain disease, but rather it is a chronically relapsing brain disease. But here's the good news. Most people actually will achieve full remission over time, especially if we can provide treatment, get them involved in treatment. The prognosis is good. Next slide. So what about language and terminology? That's the last thing I'm going to talk about. Next slide. So next slide. There's lots of different terms, of course, that we hear every day, probably, in the field, if you're working in the field, but also in the media related to these problems, substance use disorders and alcoholism and addiction and dependence and abuse and harmful use, etc., as well as people suffering from them. Next slide. And some of these are more pejorative terms. Some of them are used in the media that we read every day or hear about. But there's a variety of different terms. Question, no, next slide. So here's a question for you. People with eating-related conditions are always referred to as having an eating disorder, never as food abusers. So why are people with substance-related conditions referred to as substance abusers or drug abusers and not as having a substance use disorder? We never refer to people with an eating-related problem as being a food abuser. People work in the eating disorders field, they have an eating disorder. It just is easy, we don't think about it. Whereas habitually, we've tended to refer to people with drug-related problems as drug abusers, alcohol abusers, or substance abusers, not as people as having a substance use disorder. Now, the world is changing as we now have adopted this newer terminology, but let me show you what happens when we do. Next slide. A question that came to my mind is, many years ago now, is does it really matter? Is it just political correctness? Is it just semantics? Is it really much ado about nothing when at the end of the day? So what we actually did was experimentally test this out to see if it does induce different kinds of attitudes when we use the term substance abuser versus describing someone as having a substance use disorder. Next slide. Next slide. And what we found was that because certain terminology, like calling someone a drug abuser or a substance abuser, may evoke notions of willful misconduct, we wondered whether that would induce more punitive attitudes as opposed to describing the same person as having a substance use disorder. And we actually, in this first study, we randomized vignettes where we described a person in a drug court situation who was required to maintain abstinence, describing them as either having a substance use disorder in half of them, or in the other half as being a substance abuser. And what we found was that clinicians, these were doctoral mental health clinicians, exposed at random to one of these vignettes that had one of these two terms, that clinicians who were doctoral level mental health and addiction clinicians exposed to the substance abuser term were more likely to view that person as less in need of treatment, more in need of punishment, and more to blame for their condition than the exact same scenario, but just using the term substance use disorder. Next slide. Next slide. We also looked at this in the general population. Similar study, next slide. Even bigger differences found here across these two different types of terms. When we describe someone as having a substance use disorder, as opposed to being a substance abuser, they were more likely to be thought to be in need of treatment, less in need of punishment, less of a social threat, less to blame, more likely to be exonerated, and less likely to be able to self-regulate, and therefore not engaging in willful misconduct. And look at the magnitude of the differences here in the general public sample. Much bigger differences here than in the clinician sample, which was also different, of course, when they were exposed to those different terms. Next slide. So think about that. Even among doctoral level, well-trained people, at random, it induces a systematic bias, even when we don't mean it. Even when we don't mean anything negative by using that term abuse or abuser, it induces these negative biases towards the same person than if we use a term such as substance use disorder, for example, which has more of a medical connotation. Next slide. Think about other terminology that we use in this field. We don't talk in any other area of medicine about dirty and clean results from a bioassay. But I hear people, even at Massachusetts General Hospital, which is viewed as one of the top hospitals in the world, describing urine toxicology results as being dirty or clean. Think about that. We don't use that kind of language in any other area of medicine. Somehow it's made its way into the clinical realm at the top levels, and you probably hear it and see it yourselves. I don't think we need a study here to understand the implications of calling a urine toxicology result dirty or clean, or somebody dirty or clean. Next slide. We've developed, along the lines of what we've been learning here, a dictionary, and this is housed at recoveryanswers.org. The idea here is that if we want addiction destigmatized, we need a language that's unified and that reflects our understanding, the things that we've learned about its etiology, its controllability, the impact on genetics in the brain over the last 50 years. And you can visit this at Recovery Answers. It has kind of a complete glossary of the terms and the stigmatizing terms, what to use, what not to use. Next slide. Google happily have adopted that dictionary and now have used that in their Recovery Month features every year. Next slide. Next slide. The American Bar Association now have adopted the dictionary. Again, recognizing the importance of language in addressing stigma and discrimination. Next slide. The International Society of Addiction Journal editors are now refusing to publish literature in their journals worldwide based on what we're finding here with these stigmatizing terms. So not allowing terms like abuse and abuser, dirty and clean to be published in the scientific literature. Next slide. Next slide. So this is happening all around the world now, I have to say, not just in the United Nations, but in many other medical societies around the world. So recommended language examples include those here. And of course, this is just amplifying what I've just said, that not to use the term abuse or abuser. We're trying right now, we have a petition right now, national petition, to change the names of our national institutes on addiction, because they still have the term abuse embedded in their names, despite the fact that nobody in those institutions would say, yes, we think they should be called the National Institute of Drug Abuse, or the National Institute of Alcohol Abuse and Alcoholism, or the Substance Abuse and Mental Health Services Administration. We need to make these changes. I think if we make these changes at the federal level, at the national level, and maybe there's a chance now with the new administration coming in that we'll be able to do this once things calm down a little bit and COVID hopefully abates next year, we hope, that we can attend to other things like this. But again, to use person-first language and concepts that have been used in the mental health field for a long time to describe individuals who suffer from these conditions. Next slide. And that's it. So I just about squeezed that in. Sorry, I was going pretty rapidly there, but feel free to use these slides, have these slides. I'd be happy to send you any articles that you want. And again, thank you for your attention and for having me come and present today. Thanks, Susan.
Thank you, Dr. Sarah, are you going to wrap up and post any questions?
Hi, so if you have questions, you can put them in the Q&A. And can you talk about, Dr. Kelly, can you talk a little bit about how long you've studied this and what do you anticipate next year bringing? What do you still want to look at in regards to stigma and how we can overcome this? What additional research is needed in your opinion?
Yeah. Well, I've been doing this for about 20 years, looking at stigma and discrimination. It's part and parcel of what I do and what we do at the Recovery Research Institute. It's hard to examine the effects of stigma at the behavioral level. This is one of the challenges we've had. And so a lot of the studies of stigma and discrimination have been done using vignette studies to look at attitudes, because attitudes do predict behavior. They're not an ultimate, they're not, a super strong predictor, but of course our attitudes do correlate with our behavior and our behavioral outcomes and projections. I think we need more research along these lines to figure out exactly, what impacts it can have for what people when. Again, I think, some of the interesting findings that we just discovered with that national study was that, even though we think a term may be beneficial, overall, universally beneficial in reducing stigma, it only may actually reduce certain elements of stigma, but increase others. And here's something that I don't think we're all that aware of. We think that, the brain disease terminology is all good and will reduce stigma, when in fact it actually reduces blame, but increases social distance and perceived dangerousness and prognostic pessimism. So we need to think and do more of these studies to understand, well, what's the best terms to use when, under what circumstances, so that we can start to address this.
Thank you. As always, your presentations continue to peel back the layers of the onion that reveal, yet more questions in terms of what we can and what we should be doing in terms of messaging and reaching the general population to reduce stigma for those impacted by SUD. So we appreciate your ongoing research, and if there's anything that we can do in West Virginia to participate in that research or pilot any type of curricula that would help inform research, we have a great group of peer specialists within our Collegiate Recovery Network, and they've been spending a lot of time on our campuses and online trying to reach our staff and faculty, the general public, to reduce stigma, since we're a little bit at a disadvantage on reaching a lot of individual students during the COVID situation. So anything that we can do to be of service to help with that, we would be more than glad to. So we appreciate you being here and sharing this information and new research with us.